All right, well, welcome everybody. It's really exciting to inaugurate this series on golf lectures. Just as a show of hands, just to kind of gauge the audience, how many people here are avid golfers? Okay, so a fair number of interested people. And how many people are golf curious? All right, well, hopefully everybody. You know, in a lot of ways, golf is kind of the perfect sport, right? It's a social sport. It's good for building relationships. It's a sport that you can play a really long time, and you're always working at it to get better. And ultimately, it's good for physical conditioning. There's a lot of walking. There's a lot of movement. And the thing with anything that requires a lot of physical exertion is that there's always the risk of injury. And so that's sort of where we come in today. And like Rick said, we're going to try to demystify that a little bit. So who golfs? All right, so this 2-year-old golfs. That's Tiger Woods. But this 102-year-old golfs as well. Here's Tim Tebow from the Jets, or who knows where he'll be next year. He's a pretty ripped golfer. And here's John Daly, you know, not so ripped. But the point is that golf is unique in that aspect. There's no other sport where you can get such varied body habitus, where you can get such varied ages and competing with each other. So in golf, careers can span over 50 years. There's a huge variety of player profiles. And because of that, you do get diverse musculoskeletal problems. So as somebody who treats golfers, that's something that you always have to keep in mind. Because everybody presents a little bit differently. Everyone is sort of like a snowflake in that respect. So what I'm going to do today, before Jenny takes the podium, is I'm going to talk a little bit about biomechanics. I guess it's not reflecting on the TV, so we'll just use a pointer. I'm going to talk about biomechanics, and then I'm going to talk about the major problems that affect golfers. Really, every body part can be affected playing golf. This is a study that was done recently, and you can see that along the bottom, you can see that there's really every body part has some incidence of injury, whether it be traumatic or overuse. But we're going to hit the highlights. So that's going to be the lumbar spine, shoulder, elbow, and knee, just because those are the most common. But afterwards, feel free to ask any questions about other things you might be curious about, wrist injuries, cervical spine, anything like that. I want to get a few key points across today. You really only take 3 things home from this lecture. I want them to be these. Number 1, golf has components of an overhead sport. It's not an overhead sport like baseball is or a tennis serve, but it does have those components. And so it's critical as somebody treating golfers or as a golfer wanting to hone one's technique, it's critical to understand that. Part of that is really understanding that a lot of energy is transferred from the legs up to the upper body during the golf swing. So a lot of people who start golfing sort of try to emulate what they see on TV, and that seems like a lot of, upper body movement and rotation. But the reality is, to transmit energy efficiently and try to avoid injury, you have to start from the legs up. And flexibility and strength are going to be the keys to injury prevention. And this is really applicable to almost anything, but it's important to remember that. Okay, so this is the famous kinetic chain. So this is what we're talking about when we talk about this energy transfer. And it really starts in the lower extremities and in the thighs, where you have the largest muscles in the body, and then it gets transmitted through the lumbar spine, up the thorax, and then eventually to the arms. But if it doesn't start the right way in the lower body, it won't end up the right way in the upper body. And so that's where a lot of teaching is going to happen. Okay, so starting with biomechanics, I think these are the 3 things that are important to examine. So the first thing is being consistent versus being erratic. And we see this difference between professional and amateur golfers. So here's Tiger Woods, and this is actually a looped video. But if it weren't looped, it would look the same, because that's how he drives every single time. So he's very consistent, and he does the same things every time. The second thing is that he doesn't go crazy on every shot. So Tiger Woods knows where his comfort zone is, and he's going to be in that comfort zone every time he drives. That's consistency. The amateur golfer, on the other hand, is a little bit more erratic. So every shot is going to be a little bit different, and you never know what to expect. And the problem with that is that suddenly different joints are seeing different forces, and that predisposes them to injury. And I can't get enough of watching this looped. It's just so amazing. This is actually how he plays. What's that? Charles Barkley. Yeah. So, okay, so the first thing to do is break down the golf swing. If we want to be consistent, how do we break down the different phases? And these are not things that you're possibly going to be able to control during a swing, but they're things that somebody can watch you do and try to start you off in the swing so that you end up being consistent doing them. So first of all, you've got the takeaway here, okay? And that's with the player facing the ball and the golf club facing the ball. And then the backswing is as the club is brought up all the way to the apex here, which is where the downswing begins. Acceleration is as the golf club accelerates and impacts the ball. And then the follow-through is after ball impact as the player decelerates that golf club so it doesn't go flying into the woods. These 2 points, the end of backswing and the end of follow-through, are points where the body is twisted the most, and they're points where the shoulders are in a maximal position of impingement. So these are we're gonna hear this a lot, and Jenny's gonna allude to these too, but these are the 2 phases of the golf swing that are most prone to injury. Okay, so let's break that nice sweet swing we were watching before down a little bit. So here's the takeaway coming, and then this is the backswing. There's the top of the backswing, and notice how the shoulder, that lead shoulder, is really in a position of impingement and compressing his AC joint. Now comes the downswing, the ball impact, and then the follow-through. And now the other shoulder, the right shoulder, that's in a position of impingement. You see there's a lot of thoracic turn there, a lot of torque. Okay. And this leads us to another phenomenon, which is the difference between the classic and the modern swing. So I think if any of us have learned to play golf in the last 20, 30 years, we've been taught the modern swing. This is something that got implemented probably in the Jack Nicklaus era where the idea was to maximize that rotation to get more power to the ball, get the ball more vertical so that it would land with more precision on the green or on the fairway and not move around so much. So it made sense for the ball, but it doesn't make complete sense for the body. And the reason is that the shoulder turn is increased significantly with respect to the hip. And what we're going to see here is the difference between the 2 techniques. So in the classic technique, if you look at these ovals, the white oval is representing the shoulders and the black oval is representing the hips. So you see that at every point during the swing, both are essentially collinear with each other. So that's very stable biomechanically. If we look at the modern technique, you can see that here, really, at the end of the backswing, you've got almost a 90-degree angle between the shoulders and the hips. So that's going to put a lot of stress on the lower back, and it's going to put a lot of stress on the shoulders. And then at the end of the follow-through, again, you can see that there's an angle there. If we look at how this looks statically in a real golfer, you see the modern, there you have that almost 90-degree angle. There are the shoulders, and here are the hips. Whereas in the classic, he's turned so that they're both collinear. And then in the follow-through, once again, you have a few differences. One is that extra rotation that the shoulders have. There's also a bit of an extended back there that's going to put some back strain. The classic one is leaning forward. It's a little bit more relaxed. This guy's probably driving the ball not as far. So back injuries, which we've already talked a little bit about. You know, we've all been there, lying down on the fairway while someone massages us and someone else looks on. But low back pain is definitely very common, okay? It's probably the most common injury related to golf. It's usually not traumatic. It usually occurs over time. And the worst phase is the follow-through. That's the one where people complain of pain the most. And once again, unfortunately for all of us, unless there's a ringer in the crowd, amateurs tend to suffer this more than professionals, probably because of our erratic swings. There's a lot of forces on the back, and the 3 main ones are compression, there's a bending force, and then there's a sliding force, or front to back. And to give you an idea of the magnitude, Olympic rowers put 7 times compression on their back compared to walking. Golfers put 8 times. So you can imagine how huge that compression is, and so that can lead to problems. Number one, right-sided lumbar pain is the one that tends to be more common. And then I'll get into the back anatomy and what exactly can be affected. But before I do that, I want to talk about this X factor, which is related to what we were talking about as far as the shoulder turn compared to the hips. So you can see this white line and this white line, they make an X. So the greater this X is, the greater that angle is right here, the greater the potential for injury. And the reason is because the lumbar spine does not have a lot of rotational capacity. It's really designed more for bending and flexing. So the 3 things that can be affected are these columns of muscle on either side of the vertebral column, called the paraspinal muscles, the intervertebral disc, which are these blue cushions, and then the facet joints, which connect the spine, each vertebrae to each other. So with a lot of rotational forces, all 3 of those things can be injured. Having said all this and understanding the biomechanics, is there any way that we can prevent this? Well, what's interesting is after all that I've said, low back pain may actually not be more prevalent in golfers than it is in the general population. So studies that look at that may just be sampling people and who have low back pain and happen to golf. In fact, what may be happening is people who have back pain may elect not to golf so often because it hurts them. But if you're one of those people, one possibility is this hybrid swing, which seems confusing to me, but it basically would be using the backswing of the modern swing, and then when you start engaging in the swing, finishing off with the classic instead of the modern, so there's a little bit less torque. But in general, I think keeping a consistent stroke is probably the most important point. I guess this combination is probably evidence that you can have it all. Anyway, so how do we diagnose these? So we get a history, we get a physical exam, and then we can get some imaging. And so to illustrate it, here we have an example of spinal stenosis where the nerve root you can see on this side in white is there's a lot of space, and then on this other side, on the right side, you can see that there isn't space. So that person probably has radicular symptoms or symptoms going down their leg. Here's a disc herniation, which you can see, and you can see over that. So once we find out what the patients have, we try to work on their swing mechanics, we get them into physical therapy, we get them to see Jenny, we do different modalities, and as a last resort, surgery. Now, shoulder injuries we sort of alluded to also during the talk. So once again, top of backswing, end of follow through, those are the most vulnerable points. And the reason is there's not a lot of space near the shoulder. So what you've got in the shoulder is you've got the rotator cuff, which connects the shoulder blade here, the scapula, to the ball of the ball and socket joint. That's the humerus. And there's a little sac of lubrication on top called the bursa. And that allows this to slide without getting too caught up on this tiny bone outcropping that's called the acromion. Well, there's not a lot of space, so if that starts getting compressed a lot, that can lead to chronic conditions like bursitis, like tendinitis, and eventually to things like a rotator cuff tear. The other thing that gets compressed a lot is this little joint here, which connects the clavicle or the collarbone to the acromion, and that can get arthritic and that can be very painful. And again, when we bring our arm around like that, that's really compressing the AC joint. So it often happens in the lead arm. Again, top of backswing and a follow through. Just repeat with me like a mantra. And then this is really the most common. The impingement, AC joint disease, and rotator cuff disease are the most common conditions causing shoulder pain in golfers. So here's an MRI that illustrates the white is inflammation. Here's that rotator cuff tendon, which is the same as this guy right here. And look at that, it's really inflamed. So this guy probably has a lot of pain. We do some tests to bring this out in patients. So this is called the Hawkins test. This is called the Neers test. And that's really just kind of mimicking what you're seeing with the golf swing. So that's why that's causing pain. Some patients have a little spike here. This is that acromion, that outcropping I talked about. when they have that little hook, they're potentially more predisposed to developing this tendinitis. And then once again, there we see a partial tear and some tendinosis of the tendon. As far as the AC joint, we can palpate it. We can do provocative maneuvers. Think about this guy. This is right at the end of the follow-through. That's exactly the position that the arm is in. This is a nice-looking AC joint, and then this is an arthritic-looking AC joint. So that's what happens over time. So how can we prevent this? Well, number one, we correct swing faults. Number two, we strengthen the muscles. And then there's some thoughts about modifying grip. What's interesting about this is no one has actually looked at this in golf. People have looked at this in racket sports a lot, about making grips wider to prevent things, especially elbow conditions, but also shoulder issues. But no one has really looked at that in golf yet. As far as treatment, we do injections. We send to Jenny again. She's really busy with my referrals. And then we can modify the swing. And again, surgery is as a last resort. And you know, surgery, a lot of orthopedic surgery is really, when you break it down, it's very rudimentary. So there's compression and there's a little spike, so we just smooth it out. So here you can see that there's a spike that was there and there wasn't a lot of space. That's the underside of that acromion. And here you see that it's nice and flat. This is an example of an AC joint that was arthritic. We put in a burr and then we create a nice space between the two bones. This is an example of a rotator cuff tear. So you can see here's the tendon. It should be attached here, but it's not, so that's torn. We put in some anchors. These anchors are connected to these stitches, and then we bring these stitches over, and then we bring that tendon back down to the bone. And so that restores the anatomy. Now the elbow is probably something that if you've ever golfed, you've probably suffered some elbow problem. And the two main ones are called medial epicondylitis, which also is known as golfer's elbow, and lateral epicondylitis. What's ironic is that lateral epicondylitis, which is known as tennis elbow, is actually much more common in golfers. It's about 4 times more common. And so it's 4 times more common. It tends to occur more in women than in men. And it's really an inflammation right here where there are a lot of extensor tendons. The main one that's affected is one called the ECRB, or the extensor carpi radialis brevis. But there are others that can also be inflamed. On the medial side, it's the flexor muscles. And the body has this nasty habit in the form of making all its muscles attached on one point, which probably predisposes it to these conditions. Once again, the grip seems to be the issue here, so gripping too tightly and perhaps maybe having too narrow a grip may be the problem behind these conditions. Here's an MRI, and it shows that there's a partial tear of that tendon. This is lateral epicondylitis, and you see it there too. And then on the opposite side, you see that that's inflamed and that the flexor wad is also inflamed there. So how do we treat elbow injuries? Well, sometimes people may complain of pain going down their arm that's around the elbow, but it's really coming from the neck. So it's always important to rule that out. So we do a cervical screening. We consent to physical therapy for stretching, strengthening, etc. A few non-operative modalities are really exciting that they've actually shown some promise. One is nitroglycerin patches. These seem to work a lot for these chronic tendinopathies. So that's kind of interesting. We can try iontophoresis. Some people have been using platelet-rich plasma. I don't know if any of you have heard of that, of getting your blood spun down and having the growth factors injected. There's some controversy about that. I'm happy to talk more about that later if you have any questions. But that's something that's out there. And then obviously changing activity, and we only do surgery for failed non-operative treatment. And surgery really consists of either open or arthroscopic, and we just cut out that diseased part of the tendon, and then we suture it back to bone. And with the arthroscopic technique, we just shave the inflamed part. So finally, knee injuries, and I put this picture because I read an interesting theory as to why Tiger Woods developed an ACL tear. But you know, knee injuries are not that common in golf, and the idea that somebody of Tiger Woods' stature injured it during a golf swing is probably slightly far-fetched. But I have heard a theory that he actually injured it during a fist pump in the 2007 PGA Championship, which apparently there's video. I tried to find the video to show you guys, but I couldn't on YouTube. But apparently there's video evidence of him doing the fist pump and sort of buckling and then limping away. but then somehow he went on to win it, so who knows. Most people tear their ACL and, you know, can't walk. But obviously, if you're this guy, there's also a possibility that you do injure your knee playing golf. So to summarize the knee issues, you can tear the meniscus, you can have arthritis, you can have patellofemoral pain, and then we address all of those similarly to what was previously mentioned. But in general, once again, the idea is to remember the key points, which is that overhead component. It starts with the legs, up the torso, and then eventually the shoulders and the arms that deliver power to the ball. And so it's key to remember that there's a lot of energy transferred there. And finally, always work on flexibility and strength as a preventative measure, and then if you're injured, to get back to your previous level. Thanks a lot.